Yes, about 20 minutes. So the first question that I have is I'm going to start with Dr. Marmarella. So you talked about targeted therapy and you talked about toxicities of targeted therapies. Are there specific patient populations, such as elderly or comorbidities, where targeted therapies should be approached differently?
Yeah, it's a great question. I think the first thing that I'd like to address is how these drugs are developed. So, when we develop a targeted therapy, one of the first things that is asked is what is the maximum tolerated dose? So, at what point do we have too many side effects that that dose is too high? The question is not asked, what is the minimum effective dose? And so I think with a lot of these targeted therapies, the dose that is approved is likely higher than what we need. So I think the first answer to that question is that we can be pretty aggressive about dose reductions, or we can start actually a little bit lower and then start to make our way up in patients that we're worried about having additional toxicity. Um, there are specific, patient populations that I think I worry about more. Certainly, the elderly, we would probably start at a lower dose if possible. But really, actually, I think these drugs are pretty well tolerated, and it's mostly dependent on which targeted therapy, whether I decide to start at a low dose and then move up.
Yeah. And the second question, I will leave it to pretty much anybody who wants to answer. Other instances where chemotherapy might still be preferable to targeted therapy, even if your patient has a biomarker positive disease?
Yeah, I can start answering that question. So there are some targeted therapies or some biomarkers where actually we do recommend first-line chemotherapy, not necessarily with immunotherapy, sometimes with. So it really depends on the biomarker. So for example, with our KRAS mutations, KRAS G12C, for example, currently our standard of care is to give these patients chemotherapy plus immunotherapy. We look at other biomarkers, for example. So I would say it really depends on the mutation. So we don't always want to rule out chemotherapy. Sometimes we have to rely on chemotherapy if a patient develops resistance on a targeted therapy. So sometimes chemotherapy can still be our friend. It can be considered, but have that discussion with your team. It really does depend on the biomarker.